Okay,
session.
welcome everybody to the session of Coronary Theater, the TCTAP 2021 virtual. So we thank you for joining us. So we're gonna have a live case session, pre-recorded live cases with a discussion with distinguished panelists too. So I have a co-moderator, Duk-Woo and as a panelist in the Dr. Jung-Min, Alaide Dr. Chieffo, Dr. Kefei and Do-Yoon Kang, and Imad Dr. Sheiban, right? So we want to start the first case, live case session, right?
Okay, thank you. Okay, thank you, SJ. And
Right.
we pre-recorded the case. We're gonna start the first case, and then during the session we have two pre-specified discussion time. I'm gonna start. Welcome to TCTAP Virtual 2021 meeting, and we are very pleased to present our very interesting case for the audience. And so, this year the COVID-19 is still active, and we prepared every live case demonstration like the virtual streaming meeting, and we're gonna start our live case demonstration, and we prepared a very interesting case. And before starting our live case demonstration, and I will introduce our super team. And right side is Professor Do-Yoon Kang, our key faculty, and another right side is Jung-Hoon Lee, our senior fellow. And okay, Dr. Lee, can you present the patient background?
Okay. 59 years old male patient was referred for treatment of the left main bifurcation, and he was diagnosed with unstable angina and underwent PCI for RCA region 1 month ago. Next. Underlying disease is nothing special, and he's an ex-smoker. 15 years ago, he stopped smoking. Next. ECG showed the normal sinus rhythm. Next. And test PA showed normal cardiac size and no active lesion in the lung. Next. Here's medication is aspirin and clopidogrel and calcium channel blocker and statin and beta blocker.
Okay, and if I'm going to summarize these patients, relatively young patients, 59, and 1 month ago already underwent a right side coronary PCI, just using the one stand, and the treated well and the proximal part. Also today we will treat the left side system. This is the first view, right?
Yes.
Okay, and this is the area coral view, and you can see that there was some very tight stenosis of a big OM branch, as well as the distal left main, and looks like some disease. And next one. This is the AP cranial view. We can see the Alaide. There was a very tight stenosis, and the region extended to the distal left main, to the mid-Alaide part. And next one. So, and this is the spiral view. We can see the distal left main, and there was seems like involved. Also, Alaide ostium was looks like very tight, and the soc ostial region and some ambiguous left main disease. Now looks like very tight. And next one. This is the initial default view, the arteriocoral view. Even in this view, we can see the soc ostium. Could you stop the imaging? Okay, over here. And on this view, and we can see the distal left main, some disease, and but the soc ostium is not so tight.
Yes.
Although some OM branch was tight, and the Alaide ostium there was some at least moderate significant Alaide ostium disease at this moment, and we checked the IBUS image and the Do-Yoon Kang, and he is our imaging specialist, and we already checked the imaging. So, and I have one question to Dr. Kang, and if we do not check the IVUS, what is your plan?
For
For such region.
left main bifurcation.
Yeah, right.
Yes. I would have a very concern about the main bifurcation disease, but because it looks not very severe in angio view, but in another view, there is some very tight disease on the left main bifurcation. So with only angio, I would have very concern about crossover wall to stent technique. I will recommend IVUS
imaging
to identify exact burden of disease and shape of the plaque.
Yeah, right.
We check the OM to left main pullback.
Could you
Yes.
play?
This is the distal normal portion of the OM, and
Previous one.
the vessel size is about 2.8, and there is some tight plaque from the OM branch. As you can see, there is eccentric plaque with the attenuation, and the image is a little bit distorted because of the angle. And now here, the tightest portion just passed, and the vessel size is more than 3, about 3.5. And now it's just a same image with the IVUS. And there's another eccentric plaque at the proximal OM branch. And now the proper circumflex would come from the now you can see there is a nearly normal region at the proximal OM, and there is a tight disease at the proximal OM ostium, and now proximal proper circumflex came in. Here is the proximal circumflex, and the vessel size is more than 3.5, and then there is a little bit plaque, but at the ostium of the circumflex, the opening to the left main is preserved and wide opened.
Okay, could you show us the bifurcation part and the polygon part? Could you
Here.
repeat over here? Stop it over here. Okay, we already checked the plaques Alaide to
Yeah.
the distal left main.
Yes, this is another IVUS pullback from the medial AD. As you can see, from the just below the septal branch, we check the IVUS, and the vessel size is about 3.5, and septal branch came in from 5 o'clock, and here would be the good landing zone for the stent. And you can see the superficial calcification, and the vessel size is of about 3.5, and here the main plaque begins with the superficial calcification and larger plaque burden and very tight disease of target. And diagonal branch is shown, and proximally the plaque is continued to the proximal LAD. And now in angiography, you can see a relatively preserved proximal LAD, and it's here. The plaque burden is decreased, and if there is no left main disease, here would be another good proximal stent edge. And now let's check the distal main bifurcation and proximal LAD. While we cover the stent or not for the LAD ostium, here the lumen is widely opened with a very large vessel. That means positive remodeling. And here is just the ostium of the LAD.
Huge plaque.
You can see the huge plaque. There is lumen is relatively preserved, but there is a huge plaque. Plaque burden is maybe more than 70%.
Okay, could you show us the bifurcation part?
Yeah.
And also usually, and if you're gonna just one pullback from the LAD to
Yeah.
distal left main, and sometimes you can overestimate the circosteum region.
Yes.
The region why we recommend absolutely to the IVUS pullback from the Alaide to left main and the circle to the left main. That was essential to decision making. And this is the distal left main part, and we can see the lumen area less than 4 in the Alaide ostium, also huge plaque, and the plaque burden more than 70%.
Yes.
Also, we can see the 7 o'clock direction, and the circle ostium is coming, it's widely often.
Yes.
So without the imaging guided PCI and the nowadays contemporary state of art PCI, and the state of art PCI can make a PCI outcome comparable, equivalent to bypass surgery outcome.
Okay, we have a discussion time, and we shows the overall the coronary angio as well as IVUS in both branch. And I'm gonna discuss how do you think about which strategy if this patient is your patient, how do you select a strategy for the distal bifurcation region?
Yeah, actually, what I see here is very tight lesion in MO that should be treated. And regarding the distal left main, the ostium of Cirque doesn't seem that much involved. So a good approach could be also considered the provisional approach in this case. About adjunctive devices to prepare the lesion, there is some calcification also on involving distal left main and the ostium of Alaide. I think it is not very superficial calcium, so I think the expansion of stents will not be impacted by the presence of this calcification. So I think we do not need a atherectomy or any other device to prepare the lesion in this case.
Okay. What about Dr. Chieffo?
Yes, I mean, I think, okay, so what I think is what I would do in this case would be first to treat obtuse marginal, and then to go on the left main, and I would start with a provisional approach. So it would be provisional T-stenting left main toward the Alaide and trying to do a provisional approach and according to European Bifurcation Club. I mean, I'm mostly sure that it would be enough. Then clearly when you do provisional, you have always the possibility then to switch into stent if you are not satisfied with the result.
Great.
Yes.
My initial thinking is perfect with you. Is the Kefei duo is a join, and
yeah.
How do you think?
Dr. Do?
Okay. For me, I think IRIS is necessary, but the better is combined with functional examination. I think if we check functional examination, such as FFR, maybe we have a chance to decrease the stent implantation. But now in China, we have UFR and OFR, the IRIS-based QFR. Maybe you have such device and maybe make the procedure more simple. For the lateral application, I think provisional is also useful.
Great.
The Jung-Min, how do you think is this case and your strategy?
Yeah, I think based on the IVUS finding, actually the decision of the two-stent or one-stent technique, we usually depend on the IVUS finding of circumflex ostium. So circumflex ostium, based on the IVUS finding, so plaque burden is small and lumen is large. So I think the provisional stenting would be a good option.
Provisional, what does it mean? Provisional stent is just stent crossover from the provisional stent. You mean the stent from the Alaide to the main crossover, and
yes,
then you want to see what's happening to the circumflex ostium. That's right.
Yes,
yes,
right.
yes.
But the one, but I want to see the actually the big ramus branch, the functional status, because the ramus branch is not small, so circumflex osteum is looks good, but the ramus branch status is another interesting point to me.
Okay.
So I think the FFR measurement would be a good option to evaluate the ramus branch status.
Okay.
So
So
who-
and yes. Okay.
All
I'm
right.
gonna proceed and more
All right,
case and
I wanna say one thing. Okay, I have no ideas what you've done so for these cases, and so okay, Dr. Doe suggests FFR for LED something like that. However, it's good. I want to do that. However, not exactly proximal LED, just mid portion of LED, quite tight stenosis. And so if we measure the FFR for the distal part, it's absolutely positive, and main lesion would be mid portion of LED, right? And
Yeah.
proximal LED concerns you've seen by others for very large plaque burden. However, minimal lumen area more than 3.5 something, less than 4 millimeter square. Still, just focus on the single lesion subset. That is absolutely negative FFR, right? So, minimize for this lesion subset. I would suggest, just a single stent with a portion of LED, just another stent, and obtuse marginal branches. And just leave it alone and remain in, ostium and circumflex ostium part by Ab's finding. It looks good, not too much plaque burden. That is first option. Right. Second one, practical point of view, not, it isn't clearly not too much separate in terms of, mid portion of LED and proximal LED and first obtuse marginal branch. It is really, anyway, just diffuse just a pre-job those step part. How, practical point of view, we do touch in terms of proximal LED, even in the provisional stand, circumflex ostium. Anyways, a compromise, you have to deploy the another stem for the obtuse marginal branches. And so, second option is more aggressive treatment. I would do, crush for main LAD and even from the circumflex and obtuse marginal branch and circumflex ostium and crush for the, bifurcation. The reason why technically, it's not so easy, even in the provisional stance, something like that. Second one, the flag is not too much in terms of LED osteopath, distal and main. If you do stem procedure, the clinical outcome absolutely, I think, is good, must be perfect. And so I really, as a practitioner point of view, we're gonna do, any stand crossing would be okay. Two stand, upfront to two stand technically what I'm talking, right? And minimize procedure as a single stand with LED and another stand, first option, obtuse marginal branch. That is my option, right?
Okay.
All right.
Okay. I'm gonna proceed with this case and second part and much
Of
interesting.
RPCI and the to bypass surgery outcome. We use the 6-branch guiding caster, just the same crossover would be expected. Okay, test. Okay, here. Okay, go. 6, 8.
8. This is
Okay,
2.5
deplete.
compliant balloon.
Okay, go. 6, 8,
8,
10.
10.
Okay. Okay, deplete.
Plate.
Okay, test.
Yes.
Okay, over here. Go. 10, 12.
10, 12.
Okay, save. Deplete.
The plate.
Okay, Angio.
Ready.
Okay, for sure. We're gonna use 3.0 on the basis of IBUS finding, and the lesion length was 35. We select 38, the Giant's stand. 여기다 그제? 자, 고. 12.
6, 8.
12.
네, 12.
Nominal.
Great.
Okay. This is stem booster. Okay. 자, 고. 12.
12.
Okay. Save. Deplete.
This is 3.0 NC balloon.
자, 고. 10. 12.
12.
14.
14.
16.
16.
Okay. Save. Deplete.
Deplete.
자, 고. 12.
12.
14.
10.
16.
16.
Save. Deplete. 충분히 저기 사이즈는 됐죠.
So what size of the stand do you use? Duk-Woo?
3.0.
Okay, 3.0.
Yeah, on the basis of IBUS.
10.
I think it's big
10.
bezel, right?
12.
Yeah, right.
14.
14.
오케이, 세이브. 디플릿.
앞에는 더 키워도 될 것 같습니다.
여기 거의 엣지까지 나왔지? 자, 고. 10, 12, 14, 16.
16.
오케이, 세이브. 디플릿. Good. Okay. Over here, and we're gonna check the IBUS. And we already measure the regional length on the basis of the IBUS, and 45.
Yeah.
And the Giant's stand is 48 is available,
Yes.
and we select 3.5, 48.
Yeah,
Yeah.
Okay,
we
got it.
select very low.
From
Yeah,
from where to where?
Target is 2,000.
yeah, it's a mid part to the left main. 48 is a Giant's long stand.
You mean this whole stand crossover, right?
Save, deplete.
Yeah, right. We are
Right.
stand
That
crossover.
would
This
be
is
very
free
hard
dilation.
to decide. Okay, go. 12,
12,
14.
14.
Okay, save, deplete.
It's a 48. It's the longest stand in the Giants.
됐다. 잠깐만 이렇게 해놓고.
Okay, there's some resistance.
조금만 더 들어갈게. 이렇게 요거지. 오케이. 자, 테스트. 얼추 들어갔다. 그지? 이 정도 같은데.
커버됐습니다.
어느 뷰가 제일 좋은가? 잠깐만. 자, 테스트.
테스트.
여기도 괜찮고. 그지?
탈이 타겟입니다.
자, 여기지. 자, 고 가자.
This is a 3.5, 48 Giants stand.
11. 3.5. 오케이. 디플릿.
This is a post balloon dilation.
14.
14.
오케이, 세이브. 디플릿.
플레이트.
오케이, 고. 14.
14.
16. Okay, save. Deplete. And NC balloon post dilation was our routine. Okay, go.
16.
Okay, 16, 18. Okay, save. Deplete. Okay, 16, 18.
18.
Okay,
18.
20. Okay, save. Deplete.
Okay.
Okay, and then the 3.5.
Main lumen size is about 4.3.
Boost over. Go. 10, 12.
This is
14.
additional the 4.0
16,
NC balloon.
Okay, save. Deplete. Okay. And then we're gonna check the spider view. Okay. There was how do you think about the angiographic finding for the spider view?
It looks eccentrically narrowed by the carina shift. The flow is okay.
Yes, carina shift or sometimes the stand strut looks like such like a very tight narrowing, and if required, we can do the next procedure, provisional kissing balloon dilation or FFR. Okay, we're gonna check the IBUS
Okay,
first.
here is the second discussion part. How do you do? And looking at the
FFR. Okay, we're gonna
osteum, looks very tight, and we should something. I'm gonna ask the expert, the panel opinion for this case. How gonna do?
Simply, Duk-Woo, it's okay.
Yes.
Personally, I think so, right? I don't want to FFR.
Yeah.
It's just, a little bit compromised circumference system. I think it's perfect. So just leave it alone. That is the answer. This is my answer. Great.
How do you think Imad and
Dr. Seoul.
Alaide and cool.
Actually, it seemed really good result after stenting distal left main. I mean, flow is okay. I think patient had not any symptom, ACG as well. I'll check by IVUS. I'll not go for FFR in this case. Again, because to avoid dissections, to avoid some, trouble with FFR, because we know that FFR wires are not that friendly used every time, and you might have some problem sometime. So what I see from Angio, I think there is no plaque shifting or carina shifting as I can imagine from Angio, but I will check with IVUS crossing distally in the stent and going for checking that. And of course, I'll do pot in left main, because I think left main, we have to expand more the stent, the portion of the stent protruding in left main.
Okay.
Yes, exactly. What I wanted to say is that provisional is not just implanting the stent crossover, but we do believe as a European Bifurcation Club, and it has been recently published, the last also consensus document, that you have to do an optimal provisional stenting, which means to recross, to do the kissing, to do the pot, and all this kind. First do the pot, and then recross distal, and do the kissing, and then the question mark if even to repot. And finally to do an IVUS to be sure anything is okay. So provisional is not just one stent across, but means also to do optimization, as also Imad was saying.
What do you think, Dr. Do?
I must say, although I suggest FFR for this patient, but this is my routine way to treat a lesion like this.
Great.
And the result is quite good. But in my opinion, I always first do recross, and then I will do kissing balloon, use a smaller balloon for circumflex. I'm trying to open the cell, and then I try to check iris, and I guess based on the iris finding, the plaque is at the opposite side of the circumflex. And I think 90% is the carina shift. After a very slightly kissing balloon, the check iris for left main. If it's fully extended, well extended, I will finish this case. Maybe a pot.
Great. Nice discussion. Duk-Woo.
Yes.
All right. If I were you, I have no idea this case. If I were you, I am also a little bit, extreme, perfectionist. I don't like a perfectionist. However, if I were you, I want to do, anyways, stent cross for that. All right. As circumflex ostium, there are some functionally normal, visually some disease over there, and you're gonna think about the provisional stent, right? So just to think about, gas. Two stent, minimal plaque, upfront two stent with the crushing, include the DK crush, right? It's okay. And just like you've done, just leave it alone, or still part of circumflex. It's a big artery, right? There are some, I believe that when you just leave it alone, it's okay. What do you think? It's compared with upfront two stent clears a big effective stent area, and you've done just leave it alone, circumflex part of some disease status. Personally, I believe, listen data, two stent maybe would be okay.
I don't. I mean, we will be looking to the result of ABC at PCR, so I cannot disclose clearly. I know the result, I cannot say anything. But the story is not like that. I can say that. I mean, let's see the final result from that study. But I think it's not, let's say in this way, it's not straightforward that two stent for left main is the solution to start with, especially in this kind of anatomy where actually the ostium of the circumflex was free from disease.
It's one short question. How the panel guess the FFR value in SOC? Looks very tight. Everyone
Every
guess
panelist,
more than.
I think it's a negative. Anyway,
Okay,
not less
so
than, hyperemic FFR is less than 0.8 something, right? It's bigger than that.
Yeah, and so I think this case is key point is that, and we already POT procedure using 4.0 up to 20 ATM, and then I'm gonna show again the final some view, and then we're gonna do something. Okay, play to the end of the here.
The carina shift.
Okay.
Is partitive
Flow is
FFR?
Okay.
I don't know.
So I think I don't think pot is always a good method.
How do you
Okay,
think
we're gonna
about
proceed.
the angiographic finding for the spiral view?
It looks eccentrically narrowed by the carina shift. The flow is okay.
Is it partitive?
So for pot technique, we need a very short balloon
looks
to
like
do that.
such like a very touching balloon dilation
or something like that. And, okay, we're gonna measure the FFR. Okay.
Okay, and easily passed.
Yeah.
Okay, good.
Yes. No damage. Absolutely. Easily passed.
And the most audience was wondering, I think, how was the status? After standing crossover, you meet such case and encounter many cases such like, and the spiral view looks like some significant narrowing.
Is it PDPA or hyperemic FFR?
And
this is now the zeroing.
Strut itself.
Yeah.
And the zeroing. Okay.
And then we're gonna proceed.
We did the saline flushing, and removing the introducer is very important for accurate zeroing.
재롱 다 했죠.
1.0, and then
okay, over here
you pass.
조금 더 들어갈까? Okay, got it. 자, baseline 0.95. Okay.
95.
If FFR less than 0.8, we do kissing balloon dilation. And above 0.8, we just differ.
Yeah.
Okay, got it.
PDPA is 0.96 is absolutely, negative FFR.
됐다. 이제.
Okay. Hyperemic, not
We are now intravenous adenosine on the 140 microgram per kilogram per minute. You can use the intracoronary or intravenous adenosine, or even intracoronary the nicorandil in some cases.
떨어진다. Okay, and for the hyperemia, here is could you see the status of FFR? And the blood pressure was down, less than 90. FFR was 0.87, right? There was a pooled hyperemic status.
Yes.
And then slightly pull back how gonna change the FFR over here. This is the stand proximal part, 0.86.
No change in the stand portion.
Okay, this is just and the subostium 0.856, and then the pull back the main part. And 여기서는
1.0.
1.0?
예.
어디까지 올라왔지? 다 올라오네. 그지? Okay, great. Okay, it's good. There's some gel. That's owing to the stand strut. Okay, test. 요뷰가 잘 보이나? 요뷰? 네. 자, 아니죠? 자, 풀샷. 오케이, subostium is good. 약간 가위치기를 해보자. 테스트? And some views show the owing to the stand strut and looks like some the shaggy change. Okay, good. Okay, and IBUS and the subostium is widely open. FFR is okay. Okay, Angio. Okay, great. Okay, this is our final result. I think this case is very,
So and
educational.
this is our the final result, and I'm gonna show the everything for this case. And finally, and angiographically looks very tight, and
Not very tight.
yeah, FFR was 0.87 on the basis of FFR. We simply leave it alone. That was our case lesson.
Okay, not finished yet, Dr. Bob. Okay, Dr. Jung-Min, can you hear me?
Yes, I can hear you.
Okay, you want something to talk, right? But in terms of FFR for what do you think?
Yes.
So what,
Yes, the main lesson from this case is don't trust your eyeball evaluation. So even that your eyeball thought your eye evaluation told us that very tight angiographically, but functionally
not so tight. You mean with
frequently, yes, frequently the FFR is more than 0.8. Or based on our previously small data set, if you do the simple crossover stenting over circumflex, the chance of circumflex FFR is less than 0.8 or is only 7%. And for the left main bifurcation, for non-left main bifurcation, 2/3 of tight circumflex ostium after simple crossover stent is FFR is more than 0.8 or. So in most cases, FFR for the side branch is more than 0.8 or. I think a simple crossover stenting would be good. But one concern is long-term outcomes. Even though simple crossover stenting, circumflex ostium would be the most frequent location of restenosis in the future. So we have to solve this problem.
right? I'm gonna focus, talk about when I look at that. You deploy the stand for the obtuse marginal branch, right? If visually almost the perfect result, if you do post stand, below the stand FFR still not, almost 1 or 0, right? There's some difference. So what I'm, focusing the last part, if you FFR measure the far distal part of a stand, I believe the stand is almost perfect, right? So not too much changes. However, if you measure the FFR distal part of stand of obtuse marginal branches, that is a final goal. How much blood supply the distal part of a coronary bed or something like that. And so, if you do measure FFR post stand distal part, still I believe the FFR value is 0.81 something. All right, this is beautiful. Dr. Sheiban, you know what I'm talking, right? There is still difference. However, totally I believe that would be negative FFR, right? However, if you measure the FFR distal part of stand, I'm sure the FFR value is 0.81 something, right?
So I'm gonna summarize the first live case demonstration. This is to emphasize contemporary state of art PCI, the involving and the IVUS. You can do freely IVUS, and there is some suspicious lesion, and you can do freely FFR. You're gonna do combine the IVUS and the FFR. You do right decision, and that was my key final message. Okay, and going to the time limit, and I'm gonna finish first case and second case, Do-Yoon Kang, and also the prepare very wonderful case.
Great case.
Okay.
Okay, this is the next case.
And we are very
also Dr. Park and I did the case of the left main bifurcation. Let's see the case.
2021 TCTAP virtual meeting, and I'm gonna happy our the excellent team showing the one of interesting case, and I'm gonna introduce and the left part and the.
Would you increase the higher volume?
Okay.
And right side is the senior fellow and the Jung-Min. So, and we're gonna start a very interesting case. This is a left main case, ISR case that would be very helpful to understand the main mechanism and some complex decision making would be helpful to expand your knowledge about the left main PCI. Okay, Dr. Lee, can you start?
Yeah. A 79 years old male patient was admitted for left chest pain, and he underwent PCI for left main, LAD, left circumflex diagonal lesion for several times, and diagnostic CA showed ISR for left circumflex lesion. He had previous PCI next, and he has diabetes, hypertension, hyperlipidemia, and he had a history of family history, and he's non-smoker, and he for chest pain for coming to our hospital. Next. EKG show normal sinus rhythm, and we can see the pathology Q wave. And next, chest PA showed no active region in the lung. Next, this case is the target region is proximal ISR circumflex lesion, and we should have chosen the intravascular imaging, and we choose the OCD, and treatment plan is DS or DB. He used aspirin and clopidogrel. Next, we can show his PCI history. In 1992 and 1999, he has balloon angioplasty for LAD and diagonal lesion. And 2005, he had the first time DS for proximal circumflex and mid LAD region for first generation DS. And 2020, in last year, he has a proximal circumflex ISR lesion and treatment with DB. And 6 months later, he first time come to our hospital. It's indicated with left side with white portion, and we had a left main to proximal LAD with giant Saira and proximal circumflex and medial LAD ISR lesion for DB. So proximal circumflex lesion is first time 2005 and 2 times ISR. And next. This is the baseline angiography. So proximal circumflex is 3 times ISR lesion. So we should have treated this lesion.
Okay, and the play right side. So, and looking at the target lesion was proximal the ISR region. Okay, back at the before slide. If I'm going to summarize a very complex history of the prior PCI history, at least 5 times, nearly 30 years ago, 92 mid-LAD balloon angioplasty, diagonal branch balloon angioplasty. The 15 years ago, put the first generation Cypher stent mid-LAD and the proximal and the up to subosteum, the Cypher 3.5 and the mid-LAD Cypher 2.75. And the patient was stable for 15 years, and absolutely 1 year ago, and the proximal Cypher ISR. At the time, we performed the DB and the paclitaxel coated balloon, and the 6 months later, and the patient and the subosteum at the time was looks okay, but the mid-LAD ISR also plaque was. The more progression, the proximal distal left main. So we put the Giants Sierra 3.528 as well as mid-LAD part DB. And so, and this time, this Angio view and the mid-LAD part is okay, and the proximal LAD left main Giants is okay. But 1 year ago, at the time, the Cypher ISR, we put the one-time DB. That was this time is exactly 1 year past, and the proximal was the ISR again. And so, nearly 6 months ago, we performed the left main proximal LAD and the stent crossover. At the time, proximal part was slightly crushed, yes. And the final kissing stem dilation is too much complex. Anyway, so. Dr. Kang, this is area coronary view, okay?
Yes.
And could you explain the baseline coronary angio?
Yes, in baseline coronary angio, you can see the circumflex proximal disease that is the third recurrence ISR. And as Dr. Park mentioned, this is very old cipher, 15-year-old cipher, and then crushed with the left main to Alaide giant stent. So the main Alaide stent is well opened with a circumflex ostial tightening. So because this is DB failure after second time attempt of the drug-eluting balloon, so I think that drug-eluting stent would be a good option for this recurrent ISR case. I want to ask to the panelists that how would you treat this kind of lesion with a very recurrent circumflex ostium after main stenosis, after main PCI?
So if I can make a comment, as far just to understand, this patient had a cipher implant in 2005 and had stenosis again in 2020, which is not a restenosis, so it must be neoatherosclerosis, and it was treated only with balloon. Is this the case? Did I understand correctly? So I think that if this is the case, this is not a restenosis, this is a new atherosclerosis, and now it is a restenosis by a balloon. That is a drug-eluting balloon, and just to understand which drug-eluting balloon, if it's a paclitaxel or a sirolimus-eluting balloon.
It was paclitaxel.
Okay, and that's the reason why. So, and that's the reason why, because indeed we have the sirolimus-eluting balloon that honestly is working a little bit better. But I would stent, because the point is that this is not this is a restenosis by balloon. It's not a restenosis by stent.
You know, your understanding is exact. Yeah. Okay.
I wanna ask you something, right? It's the relation of the circumflex, cipher stent and Bainbridge giants. Is what technique do you use? It's kind of a stent crossovers, T stent, something like that, right?
Circumflex, in 2005, the circumflex ostium was firstly stented with a precise placement at the ostium, then with the Alaide was stented. And then 2020, we crushed the circumflex cipher with a minimal protruding, minimal protruding stent was crushed.
Minimal crushing.
Yeah, right. Exactly.
Minimal, protruding is just a crush with a minimal crushing, right?
Definitely.
Okay,
yeah, right.
Right.
So if I'm going to summarize, this is a very recurrent case, and the ostium implanted stent, cipher stent, and 1 year ago ISR, we did a drug-eluting balloon, and just after 1 year, and the re-ISR, is how do you treat? Yeah.
I think it is important to have some intravascular imaging in this case to see what happened there. And then after that, you can decide more appropriately what to do.
Great.
I agree to your opinion, Dr. Imad. So I will share you that what we saw in the intravascular imaging.
Okay, so Dr. Kang, go proceed. Okay.
Yes. This is the OCT view.
Can you re-initially perform the Alaide to remain?
Yes, this is a first pullback from Alaide. And as you can see, you can visualize the stent strut very well with some shadows. And this is the left main. You can see there is no neointimal hyperplasia because it's just 7 months ago the implanted stent. And
absolutely clear.
Yeah, very clear stent. And this is the ostium of the circumflex. Okay, is it right? Yeah, this is the ostium of the circumflex, and as you can see, there is some bare portion of the circumflex ostium. So we check the circumflex purvae for the visualizing.
This is Abbott OCT system, very helpful too in the core registration.
Yeah, that's right.
Coronary Angio as well as OCT imaging. Is we can find the exact positioning of the OCT matched in the coronary angiography.
because there was some tight stenosis. 뒤에서부터 볼까요? 천천히. Because there's a very tight stenosis, I could not see the distal portion of the tight stenosis, and I will check again. And here, you can see very tight, soft plaque, soft neo-intimal hyperproliferation encircling the lumen just 7 months after final DEB. And here, you can see the ostium of the circumflex. 쭉 천천히 나가봅시다. 예.
This is left main.
Yes, this here is left main, and as you can see, 더 안쪽으로, 더 안쪽으로.
This is the main, right? Would you show us the circumflex?
There's some bare portion. Here is the ostium of the circumflex. Let's move to the left main slowly. Yeah.
Okay.
And there is some uncovered portion of the carina at the circumflex side. Maybe the circumflex stent was placed just inside the circumflex, and we covered left main to Alaide. There is some bare portion of the circumflex, just ostium.
Okay, one of two struck the bare portion of the suck ostium.
Yeah.
And this is a 3.5 non-compliant balloon. And if you're going to treat the ISR lesion, aggressive, the pre-stenting lesion preparation is very important for optimization of the stenting. Okay. This is 3.5.
Test.
Okay, got it.
Yeah.
Okay.
Nominal.
Here. Nominal. 12.
Deflation. Yeah. There's some sliding of the
sliding over. Okay. 한번 빠지면 천천히 해봐. Okay. 자, slowly.
3.5 NC. 10. Okay. 14.
Okay. 14. 20. Okay.
22.
잠 찍고. Okay. Sliding. So one more time.
Yeah. Try one more time.
No, that was frequently happen in the ISR region. It's a neo-intimal and very hard feeling, and during the inflation, and there was some slippage of the balloon, NC balloon. Okay, 12, 14, 16, 20. Okay.
Save. Because we do not need full cover the ostium of the left main, and the distal portion of the previous stent is relatively clear.
Okay.
So I will cover in-stent tight portion with 23 millimeter stent. Test.
조금 더 나가도 되지 않을까?
Here. Okay. Test.
갈까? 자, 12.
This stand is a giant stand, right?
Okay, save. Deplete. NC는
What is the size of the stand? 3.5?
Is it Do-Yoon? 3.5 giant?
3.5 giant stand.
Okay.
Inflate.
To cover the bare portion, the tulip.
5.
Technique.
Okay. Tulip.
12,
14,
16. Okay, save. Deplete.
20. Apply the 3.5 NC again. This is some edited version. Nominal.
12.
18.
20. Okay, save. Deplete.
20. After NC ballooning of the circumflex, I'm trying to rewiring into the Alaide.
나쁘지 않다.
This is just BMW wire.
Okay, great.
One comment here is we need to rewire from the distal cell and make sure after keeping blown there is a smaller mental career.
Great. Okay, excellent. Okay, great, wonderful. Here we remain the last final kissing things. Here, and we put the smaller balloon.
Yes.
Okay.
It passes well.
Okay, 열어볼게. 자, 12, 14, 16, 18, 20. Okay.
What is the size of the balloons you are using?
This is 2.5 balloon. It was small balloon to open the strut. Stand, abdominal 12, 3.5 and
we now doing anchoring. This is 4.0. Okay, great. Deflation. Okay, good.
Alaide 4.0, SOC 3.5, right?
Okay, great.
Wonderful.
4 NC balloon.
SOC 20.
Okay, SOC 20. Yeah. Deflation. 3.5 and 20.
Okay, Alaide.
So 3.5 with 2.5 for kissing, right?
No.
4.0 at LAD, 2.0 LAD, and 3.5 circumference.
Okay.
3.5 SOC, yeah.
4 and 3.5.
Okay, great. One,
Okay.
2, 3.
To gain the maximal lumen.
Excellent.
Yeah.
Okay. And then, wow, excellent.
Left main size is huge.
여기는 안 붙여도 좀 더 붙일까?
There's a little bit malrotation at the
10mm 정도.
main ostium. What is the size?
조금 더 하나 10mm로 붙이면 좋겠다.
Even after 4.0 and 3.5 NC kissing, there was some malrotation.
5.0으로 10.
Then we will use 5.0
and 10
for optimization.
Okay, great. 12.
This is 5.0 NC.
Yeah.
Large volume.
16. Okay. Deplete.
Check. Okay. This is Alaide view. This is the previous 10, and here
is coming the
circumflex came in, and this is the left main ostium. Very expanded.
Very expanded. Okay. I think this is a very interesting case, and recurrent and 3 and 4 times ISR, we put the additional new drug lowering stent on the basis of the evidence-based medicine, like a Telarus trial, Telarus study, and this is very helpful to informative for and further rethinking about if you meet such like patient. Okay, we're gonna check the final angio. Okay. Excellent, good. And the spiral view.
OCT 3D 하나 띄워주세요.
Okay. Oh, great. Excellent, great.
This is the final image and the final OCT.
Dr. Kang, could you
Excellent.
summarize and last comment to give helpful for audience and what is your last closing?
This is very difficult case for decision making, and we already tried the DB for recurrent ISR and used the DES for left main ISR, and we used the DES and then used the culostenting and used the OCT imaging, and with all the combination of these techniques and knowledges, maybe I'm very satisfied with this good result.
Okay, could you lastly explain the 3D OCT?
Yeah, this is very good, very strong advantage of the OCT, that with a higher spatial resolution, we can make 3D image, a very offensive image, and can visualize the bifurcation.
There was the circum-ostium and facet view. It looks like widely opened, and the strut is widely opened. Wow, very nice.
Very nice image. Rotate. And we can also see the guide wire and rotate the image.
Very nice.
To see the angle and carina.
Yes.
And
excellent.
Succeeded to
and
gain the
I hope every audience really enjoyed this is a very interesting and very complex case, and we shows the OCT guided left main the complex PCI, and it would be helpful to widely expand your knowledge about the left main PCI. Thank you for your attention.
Thank you.
Great. I really enjoyed that one. Great cases, right?
Yes, certainly.
However, in case of ISR, so it's really one of the good options to restand another differential stand. However, you mentioned too much about the uncovered area. However, this case is really the restenosis occurred in stent, right? And so you want to treat an ISR lesion, is not a uncovered regions of that. And so,
Right,
however,
right.
it's perfect ideas and perfect results. I really enjoy that. Right?
Yeah, great.
Right. Another.
I have one question to Dr. Kang. Yes, congratulations, very nice result and perfect techniques. But I have one question about the location of ISR is the same.
Yes. Because we could not review all the images, but the location of the circumflex ostium ISR was same at the same position, just below the ostium. So we tried to cover the recurrent ISR area with a new stent.
I think this was a very good example of the importance of intravascular imaging, because the under expansion or malapposition of the stent lift main will not be discovered by angio. And second, the importance of POT in distal lift main interventions, because otherwise you will leave every time malapose stent if you are not going for one-to-one balloon expansion in lift main.
Dr. Chieffo, any comment on that?
Yeah, I think there were two great cases. Again, the story is not still sorted out, the story of the ideal or optimal stenting strategy, and I think that we will have good answers from the ABC main trial that is going to be presented at PCR as late-breaking clinical trial, and it will open again discussion on this topic. And clearly there were two great cases, very educative and very well performed, as always, by your team.
Thank you. Dr. Do.
Great case, very educational. I think the audience will learn a lot from your case. And one suggestion is, maybe if we don't use aerodolimer stent to treat this lesion, maybe we can laser first and cutting balloon and try DEB again. That's an option.
Right.
But I still think the aerodolimer stent is best way for this patient.
Great. I will do so. Right? If you didn't do another stent for that.
Yeah.
Okay, Duk-Woo.
Yes. So and
it's great. You have to close it.
Okay, and that this all case is the routine, the complex left main case. We're gonna try to show the at best our complex PCI case using FFR IVUS. Sometimes we use the OCT, even left main bifurcation stenting, and that is a good example for complex left main PCI case. Great, wonderful.
All right, so you have to close the session.
Okay, thank you everyone, and we are very happy to invite the left main expert in the world in Italy, and you appreciate Imad, Sheiban, Alaide, Chieffo. We expect a lot of things from the EBC main trial. Also joined from Phi Hospital, Dr. Do-Yoon, and really appreciate you joining, and your comment is very excellent, and this session would be very helpful to expand the left main PCI knowledge. Really appreciate. Thank you. We're gonna close this session. Appreciate. Thank you.
Great session. I like it. Bye.
Yeah.
Bye.